good afternoon. I want to thank you for the invitation, and I want to thank you for the chance to speak about psychological issues on this evening or on this day. My name is Christoph Artz, and I work as a clinical psychologist at the Ordensklinikum in Linz, as was said before. And I'm responsible for the psychological support of the departments ENT and urology. Today I'm here to talk to you about anxiety in prostate cancer patients, and how common is it, how does it change through the course of the illness, and how it affects the outcome of the treatment and the quality of life of our patients. Prostate cancer represents the most common form of non-cutaneous malignancy. As we can see, when we look at the incidence rates, more than a quarter of all cancer forms regards prostate cancer. And with an aging population and increasing utilization of prostate cancer screening, the incidence rates are predicted to keep increasing. Depression and anxiety are two of the most commonly experienced psychological conditions faced by patients with cancer. They are associated with unique psychophysiological side effects that importantly encompass poorer treatment outcomes, increased periods of hospitalization, and higher mortality rates. But I will come to this point in more details later. With the advance in treatment efficacy, cancer is being increasingly viewed and treated as a chronic disease that can be effectively managed for many years, as we just heard before. And as we heard before, the longer the illness can be managed, the longer it means it's a possible suffering. Many of my patients experience their cancer diagnosis as a clear cut in their biography, as a loss on multiple scales. The most evident loss is a loss of health, and in combination a loss of certainty or lightheartedness. The treatment in most cases also means a loss of continuity in private, job-related, social and personal roles. And on a physical scale, it means a threat or a loss of fitness, virility, manhood, and continence. In many cases, the real adaptation process, the mourning work, starts after the completion of treatment. So there are at least 3 stages of the process. The first is the trauma-like diagnosis of an existential threat. In the next step, the experts take over, and the patient is confronted with a subjective, sometimes alien world where he is committed to the medical environment. And at this phase, my patients often refer to a loss of control and a feeling of dependency. Finally, the post-treatment phase, where the patients are confronted with an altered self, altered needs, and altered values or goals. In this phase, there are often no more clinical experts who guide the patients through this process. In best case, their families and their social environments assist them, but they have to find individual solutions and approaches to cope with their new reality, to cope with their sorrows of relapse, and to find a way back to a feeling of secureness and safety, a way back to normality. So as we can see, there are indeed a lot of reasons for anxiety to evolve. I, as a psychologist, try to support and evolve existing and new coping strategies so that the anxiety remains acceptable, appropriate, and subclinical. In the moment of the diagnosis and the course of cancer treatment, it is perfectly normal to be anxious and to live through various of emotions. No magic trick will prevent that. It's part of the coping process, you can say. It's part of being alive. The real problem starts if the anxiety loses its functional aspects. This condition normally is characterized by a chronic state of hyperarousal, feelings of not being up to the task, the inability to distance oneself of fear-driven thoughts, rumination, sleeping disorders, or constant suppression of aversive emotional states. Our goal is to recognize these warning signs and to identify dysfunctional coping strategies, bad social conditions, and other risk factors for developing clinical relevant anxiety or depression. Let's have a look at the coping process in the way of a more general theoretical stress model, which is, as I think, very suitable to illustrate the stressful nature of cancer disease. We can see, in first place, the individual has to realize, to process the information and implications. Here the first problems normally appear as the threatening information is often not being processed as a whole. It needs careful communication, and sometimes it would need more time and more explanation to really reach the individual. In the next step, the interpretation, the information is being categorized as, in our topic, dangerous and even more as loss or threat. In the course of disease, sometimes patients can experience the situation as challenge, and sometimes this changes a lot in the handling of the situation. Subsequent, the individual analyzes the situation and balances threats and resources. Some may find out that they can and will handle the situation with their available resources, which means social support, pre-existing coping strategies, attitudes towards the illness, confidence in the treatment, and their ability to adapt and recover and so forth. In many cases, patients are doubtful and further coping is needed. We distinguish, for example, problem-focused coping, as you can see here, from emotional-focused coping, and try to analyze in which ways we can further support the patients. Problem-focused coping would mean that one would try to change the situation itself by utilizing new treatment options, additional aids and devices. In emotional-focused coping, there is no change to the situation itself, but the attitude is trying to be changed, and the point of view one has to the illness or the emotional experience. If the coping is successful, the experience of stress and anxiety is diminished. Otherwise, or because of new stressful events or informations, the patient can find himself in a loop of unsuccessful coping attempts, which normally leads to anxiety and or clinical relevant depression. So this is just one crude try to break down the complex psychological occurrences in the context of an oncological disease. But we have limited time, so I'm not up to go into too much details here. So do we know how many of our patients suffer from anxiety or depression? There was a great review of the existing literature in 2014. Maybe we can have a short look on the figures. As you can see, there are three phases: pre-treatment, on-treatment, and post-treatment. And here you can see the percentage, the incidence of anxiety, which is the red columns, and depression, the blue columns. As you can see, the prevalence of anxiety in prostate cancer patients prior to undergoing treatment was 27%, and it drops to 15% during treatment and is rising again to 18.5% after the completion of the treatment. Similar to anxiety, the incidence rates for depression are 17%, pre-treatment, 14.7% on treatment, and 18.4% post-treatment. I think this impressively highlights that psychological burdens are common and not finished with the end of the treatment, but that they often persist. And that should not only be an interesting fact for me as clinical psychologist, but for anyone involved in the process and course of oncological disease. We have numerous studies to show us why. How does anxiety and depression affect the outcome of treatment and the course of convalescence? Let's have another short look. Here are a few examples of study results to point out the consequences of anxiety. The study from Smith, Grimm, and Dickens found out that after controlling for the effects of pain and illness severity, anxiety and depression were independently associated with global health status, emotional and cognitive functioning, and fatigue, as assessed with the EORTC Cancer Core Questionnaire. Watson and colleague found a significantly increased risk of death during the 5 years of a prospective survival study in patients with a high score on the hospital anxiety and depression score, which is a scale which measures anxiety and depression. Di Matteo found a significant relationship between depression and non-compliance with an odds ratio of 3.03, which means that compared with non-depressed patients, depressed patients, the odds are 3 times greater that depressed patients will be non-compliant with medical treatment recommendations, which is a major risk factor for poor outcomes. Tavlarides and colleagues showed us that higher levels of cancer-specific anxiety are associated with poor sexual function and increased depressive symptoms 1 year after prostatectomy. So we really try hard to optimize treatment procedures, surgical techniques, and equipment, but as we should see from this data, there is a really big chance in optimizing clinical outcomes and quality of life in keeping track of our psychological conditions. And that brings me to the end of my presentation and to my take-home message. Psychological issues are common comorbidities with prostate cancer. The assessment, diagnosis, and treatment of depression and anxiety are key or should be key priorities for clinical oncology teams. Anxiety and depression are major predictors for clinical outcome and quality of life. Psychological counseling and therapy is standard in the treatment of patients with prostate cancer, and you should make your worries and fears to a subject of discussion with your oncologist, and don't hesitate to ask for psychological support if needed. Thank you.